Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Welcome to my presentation on parathyroid 4DCT. My name is Rivera-de Choudens. I'm a clinical assistant professor at the University of Michigan Division of Neuroradiology. Usually patients have 4 parathyroid glands in fairly symmetric positioning. The superior parathyroid glands are located in the posterolateral surface of the middle to superior thyroid pole, and the inferior parathyroid glands are located about 1 centimeter from the inferior thyroid pole. On average, these glands measure 5 by 4 by 2 millimeters and weigh about 35 to 50 milligrams. They tend to be oval, bean, or spherically shaped or kind of elongated. About 15% of patients have ectopic glands, so it's important to review the imaging from the angle of the jaw to the pericardium. Usual ectopic locations include about the esophagus, carotid sheath, in the superior mediastinum, including intrathymic, and within the thyroid gland. Patients with hyperparathyroidism tend to be women greater than men in the 5th to 7th decade. Most patients don't have risk factors. Their labs are going to show hypercalcemia and elevated parathyroid hormone. These patients, about 88% of the time, have adenomas. If not, you're probably dealing with multiglandular disease or gland hyperplasia. The diagnosis of a parathyroid adenoma is a biochemical one, so no imaging is required. Imaging choice depends on local imaging capabilities, radiologist or nuclear medicine expertise, and surgeon preference. Imaging options include ultrasound, parathyroid cystometry, and 4DCT. Thyroid 4DCT technique uses 3 phases: a non-contrast phase, an arterial phase, and a delayed phase. Imaging is from the angle of the mandible to about the carina with relatively thin slices. Its great benefit is in that it has excellent spatial resolution and anatomical detail and can differentiate between lesions. When you get a 4DCT, it's best to use a systematic approach for evaluation. Start with the arterial phase and look for an arterially enhancing lesion. Look at the usual eutopic locations of the glands. If you don't find anything, continue your search for ectopic locations. If you find a lesion within the thyroid gland that you suspect is a parathyroid adenoma, recommend an ultrasound. Then compare your lesion to the thyroid gland in the non-contrast phase. It should be relatively hypoattenuating to the thyroid gland. If it's isoattenuating to the thyroid gland, you may be dealing with ectopic thyroid tissue. Afterwards, continue to the delayed phase and look for washout. It's important to note that there can be variable patterns of enhancement, cystic components, fat, fibrosis, or even hemorrhage. Review any prior imaging that is available to you. You're really trying to answer 3 questions. 1, is it arterially enhancing? 2, is it relatively hypoattenuating when compared to the thyroid gland in the non-contrast phase? And 3, is it lower in attenuation than the thyroid gland in the delayed phase? So let's take a look at this example. We have an ectopic parathyroid adenoma in the superior mediastinum, which shows arterial enhancement, slightly greater than the thyroid gland, with a mean of 309 when compared to 293 below. Then we go to the non-contrast phase and see that it's relatively hypoattenuating when compared to the thyroid gland, with a mean of 53 compared with a mean of 76 in the Hounsfield units. And then we go to the delayed phase on the right-hand side and see that it shows the washout with a mean of 178 when compared to the thyroid gland, which shows a mean of 213. So it's relatively hypoattenuating when compared to the thyroid gland in the delayed phase. So in 4DCT, there are 3 main types of enhancement patterns. The one we just saw is a type A, where the adenoma shows a higher attenuation than the thyroid gland in the arterial phase and lower attenuation in the delayed phase. But that only accounts for about 20% of patients. More commonly is a type B type of enhancement pattern at about 57% of the time, where the enhancement in the arterial phase is not greater than the thyroid gland, but it does show lower attenuation in the delayed phase. And finally, there's a type C, where it neither shows higher attenuation to the thyroid gland when compared to the thyroid gland in the arterial phase, nor a lower attenuation when compared to the thyroid gland in the delayed phase. Now you've found a lesion, it's time to write our report. Remember, our purpose is to help guide surgery. So note the number of lesions, their locations and size, and their relationship to adjacent structures. It's best to talk about things the surgeon will see during surgery or can palpate, such as the cricoid cartilage, the thyroid poles, or the tracheophageal groove, and specifically not talk about the C-spine level. Talk about your degree of confidence, the diagnosis of a parathyroid adenoma. If you're not sure, you can add a differential diagnosis. And then talk about any concurrent thyroid pathological conditions. You can use your local template, or if you don't have one, you can go to the AJNR website and use their template. Here's an example of a typical case. If you start with the non-contrast exam, you may not see much. But then in the arterial phase, you may find this comma-shaped lesion in the right paraesophageal region. And then you may say on the contralateral side, there may be some apparent comma-shaped lesions, but if you follow those, you can see they're tubular and essentially vascular structures. Now you compare this lesion in the other phases. So in the non-contrast phase, you can see how that lesion is hypoattenuating relative to a thyroid gland, so it's not ectopic thyroid tissue. And in the delayed phase, you can see how it shows decreased attenuation relative to the thyroid gland. So we have an arterially enhancing lesion, which is relatively hypoattenuating to the thyroid gland in the non-contrast phase and shows washout. This is a probable parathyroid adenoma, a candidate lesion. We review the prior imaging, this parathyroid system-IBI, which shows no lesion, likely due to the small size of the lesion. So during the surgery, they monitor the parathyroid hormone, and their goal is to have that reduced by at least 50% when they remove the gland. So here's an example of parathyroid hormone being monitored in the surgery. It was elevated at 132, and by the end, it's about 50. So this small little bean-shaped structure was the parathyroid adenoma. Here we find another example where we find an arterially enhancing lesion, but this time it's within the right thyroid lobe. So there we're in a diagnostic conundrum. Is this an enhancing thyroid nodule or is this an enhancing parathyroid adenoma? We compare the lesion in the non-contrast phase to the thyroid gland, and we find that it's relatively hypoattenuating with a mean of 30 compared to about 55 for the thyroid gland. Then we compare the lesion in the delayed phase, and we find that it has about iso-attenuating density in the delayed phase. There's really no difference between the nodule and the rest of the thyroid, so this is a challenging one. We could recommend a thyroid ultrasound for further evaluation. In this case, this patient had a system-IBI, which you can see here in the coronal plane. There's something with high uptake in the right thyroid lobe. In the axial views with the CT, we can see that there's high uptake in the right thyroid lobe. So this was determined to be an intrathyroidal parathyroid adenoma. Here's another example. If we start in the middle with the arterial phase, we see an arterially enhancing lesion inferior to the left thyroid lobe. We go to the left where it's a non-contrast phase, and we see that it is hypoattenuating relative to the thyroid gland. And on the right side is the axial view delayed imaging. Here's the same lesion, but this time with the ROIs. And you can see how it is arterially enhancing, but not to the level of the thyroid gland. In the non-contrast phase, it is hypoattenuating with a mean of 21, compared with a mean of 72 in the thyroid gland. In the axial view, we see delayed imaging where it does have washout lower in attenuation to the thyroid gland. So we're fairly sure this is an adenoma. This is that same lesion in the ultrasound with contacting the left inferior thyroid pole. And finally, this is a post-op where they did intraoperative parathyroid hormone monitoring and they got good results. Hope you enjoyed that presentation. These are my references and good luck.